work. So rheumatoid arthritis is an inflammatory autoimmune disease. As we all know that it attacks the synovium and causes destruction for joint, for bones and ligaments. It can cause cord compression, brainstem compression, and spinal instability. So its prevalence around the world is 1 to 3%, and one of the most common autoimmune disease. As Professor Arfaj said, we see it less here, but it is more around the world. The cervical involvement reach up to 86, and there is a wide variation. Lumbar can be affected also, and it's more in women. It's around 3 times than men, and it happened before the 6th decade. Again, it's synovial inflammation that will result in weakening of the ligaments and bone destruction, penis formation, that will lead to instability and subluxation. And usually cervical disease began early, within the first 2 years. So when we look at the literature, we will see a limited report regarding asymptomatic rheumatoid arthritis in cervical spine. But with symptomatic patients, we find that they are at risk of progressive neurological deterioration and even death because of basilar invagination. The first reported case of medullary compression in patients with rheumatoid arthritis was reported by Davis and Markley in 1951. Then Mikulski examined 104 rheumatoid patients in postmortem, and they found an incidence of 11% of cord compression, 7 with basilar invagination, deemed the cause of death. Boden et al., he followed 73 patients for 20 years, and he found a neurological deficit in 57%. 7 treated non-operatively, 6 of them, they died and deteriorated and died within 4 years. So this will stress that on managing of the rheumatoid arthritis with aggressively to avoid that cord compression and brainstem compression. Marked and Sharp noted 50% mortality rate in patients with cervical myelopathy who treated again non-operatively. So a recent 10 years follow-up of 161 patients, they found there is a variation between the radiological finding of rheumatoid percentage of finding in X-rays or in radiological and with the clinical presentation. They found 50% changes on radiological or there is progression in X-rays, and they found less increase on clinical presentation. So even if there is changes on the radiology, it couldn't appear as a clinical presentation. But luckily that we find that less patient needs surgery because of early diagnosis of the patient and starting the medical treatment. Medical treatment nowadays decrease the need of surgery. A cohort study following 680 patients, they found that only 2 patients underwent surgery. And that's why thanks for Professor Arfaj and rheumatologists that the medication and early diagnosis decrease the need of surgical intervention. Many factors affect, some of them the male sex and rheumatoid factor and others. So there is 3 common pathology affecting the cervical spine, rheumatoid arthritis. The common one is the Atlanto-Axial Instability, then Basilar Invagination and Subaxial Instability. So regarding the AA instability, it reached around 49%, and there was erosion of the dens, rupture of the transverse ligament posterior to the odontoid, and most common subluxation is anterior. It reached around 70%, but we can't find any other subluxation, lateral, posterior, or even rotational. So we can see this is 2 measurements here, the anterior Atlanto dento interval, and the posterior Atlanto-Dental interval. Usually there is increase. If there is increase in the AADI, there will be decrease in the PADI and decrease in the space available for cord. Some reports suggest the AADI to be an indication for operation. The normal one in adult is less than 3 millimeters, and some suggest 8 to 10. But most of the report, they said it is not an accurate indication, and they prefer the PADI as indication for surgery. So penis formation, it occurs in 40% within the canal, and that will cause a stenosis and aggravation of the cord, and to reach around 10% cord compression due to penis formation. Vertebrobasilar insufficiency may occur because the involvement of the joint around the CVG joint. So initially, this pathology is dynamic, but with the formation of penis, it will prevent reduction and become unstable. It doesn't move. So what's about the basilar invagination? That's a novel inflammation of the Atlanto-Axial and Atlanto-Occipital articulation. There is destruction of the bones and cranial setting or Atlanto-Axial impaction. This is, we can see here, the basilar invagination, and there is near the brainstem, still didn't. So it is less than the first syndrome, and it reached around to 32%. It associated with worse prognosis and risk of brainstem injury and sudden death. That's why management should be started earlier as possible before reaching this level. Subaxial instability, less common. It reached around 25%. Affect the facet capsule joint, but because of the disc and the wide range of the wide range of the bone involvement and the disc, so it's less common than the upper cervical, which there is no wide space for articulation. So subaxial instability is relatively later finding. So it is the third stage, and it can come with a staircase deformity. So it affects any joint in the rheumatoid arthritis, affect any joint in the body and any presentation. But regarding spine, the most common is neck pain, which reach around to 8%. And C2 nerve affecting will cause occipital pain, ear and face pain. And there is clunking sensation with extension of the neck. Neurological finding is less. It reaches around from 7% to 34%. It can present with compression of brainstem, myelopathies, and late stage even bowel and bladder incontinence. So Collins et al. Demonstrate that the patient with rheumatoid arthritis undergo total joint arthroplasty. They found 61% evidence of dynamic AAI, although only 50% were symptomatic. This is what we said before, that there is difference between the radiological finding and the clinical presentation. So an AP lateral view, a flexion extension, and open mouth view is an important as for diagnosis, for investigation of this patient. Sometimes X-ray will be difficult to interpret because of osteopenia, deformity, and destructive changes. CT scan, it's good to evaluate the bone, but still we need the dynamic view to evaluate the stability. Again, it's good for preoperative planning. MRI will tell us what is in the cord, myelomalacia, relation between the odontoid and the brainstem. Also, the cervicomedullary angle range is between 135 to 175, and there is report that angle less than 135 degrees generally correlate with myelopathies and paralysis. So, non-operative treatment. how can we go back? So what we do in non-operative treatment as a surgeon, close observation and radiological monitoring is a part of our non-operative treatment. And if they find any progressive changes, patient will be considered for surgery. Soft color can help in alleviate mild occipital cervical pain. Patient with poor surgical candidate, we can use him a color, but that will not alter the progression of the disease. So most important, patient with rheumatoid arthritis have a systemic disease. So increased mortality with pulmonary disease, cardiovascular system, and anti-rheumatic medication is a risk for pre-operative. So this is some medication of which patient using. Aspirin should be stopped. There is no report, it didn't show any benefit from stopping the corticosteroid or methotrexate before surgery, but biological response, there is no good review, so it's recommended to stop it 2 to 4 weeks before surgery and restart it 1 to 2 weeks after surgery. Intubation is difficult. Consider a fiber optic assisted intubation. There is mortality rate obstruction about 14%. So the primary objective is decompression, stabilization, indication, spinal instability, unremitting pain, neurological insult, and retrospective natural history studies strongly suggest a substantial risk of neurological progression and mortality in neurological symptomatic patient. We will see it when you go. So Boden et al. Suggests the following radiological indication. First, PADI less than 14 millimeter in basilar invagination with odontoid, migration 4.5 above the McGregor lines, and subaxial subluxation with a canal diameter less than 14, and as we said, less than 135 degree of cervicomedullary angle. So regarding the AS instability, if the instability is reducible, the reduction can be maintained with any procedure, Prox, Galley, or transarticular C1 lateral mass, C2, but wire technique, it's not enough. He should be in Hall traction. So this is some of the techniques here. If it is not reducible, sublaminar wire are generally not advisable. Laminectomy should be done to increase the PADI to 14 millimeter. And if there is a space occupying panels, usually it restore with rigid embolization. No need for surgical resection. It's because of the abnormal anatomy, and pre-CT scan and navigation will be very helpful in putting the screws. Basilar invagination, some studies suggested that surgery at the onset of neurological impairment result in improved patient function and prevent disease progression. But on the other hand, if there is a significant neurological impairment, the morbidity and mortality of surgical intervention will be very high. So indication for surgery: pain, neurology deficit, asymptomatic patient with MRI changes. Even if he is symptomatic and there is MRI changes with brain stem compression, he should be operated. Because if there is a severe myelopathies, he will have more high mortality rate. A symptomatic patient with fixed basilar invagination and non-cord compression can be followed conservative. So preoperative halotraction is useful if traction successfully provide posterior fixation. If traction is unsuccessful, stage it as a posterior fixation, and upon depending on the compression, if it's anterior, go transoral; if it's posterior, go with laminectomy. Subaxial instability. So halotraction will be a good choice, as far as if fixed subluxation cannot be reduced with the halotraction, or so anterior decompression with corbectomy and posterior fixation is needed, but if it's mobile subluxation, treated with traction and posterior fixation. So outcome, surgical decompression and diffusion is proved very effective in the treatment. But the neurological recovery is less than, we don't have that much benefit in neurological recovery, and it depends on the pre-op situation. This is the Rheumatoid classification, and that will, one, no deficit, subjective weakness, objective weakness, but there is ambulatory, no, not ambulatory. Budin et al. Found it's 100% improvement, some improvement in Rheumatoid 2 and 62 in Rheumatoid 3. And found that PADI, as we said, is a good predictive factor. So in another study, in 160 patients, they found 97% improvement in pain compared with 45% improvement in function and pre-mortality rate of 10. So surgical treatment, it depends on the preoperative condition. Allard et al. Reported 16 patients treated surgically. 4 of 5 with significant myelopathy died within 3 months of treatment. Numerous studies have supported the importance of early recognition and surgical treatment. So there is complication, mortality, instrumentation failure, osteopenia, recurrent. And in conclusion, that early diagnosis of rheumatoid arthritis, early treatment by medical treatment will decrease the need for surgical intervention. Try to treat the patient with Atlanto-Axial before it reaches the Odontoid Invagination stage, and as patient is preoperative condition, neurological condition of patient will indicate what is the prognosis of the patient. Thank you.